everybody. Welcome to March Grand Rounds. Today we have Dr. Brown talking to us about movement system syndromes and how it's the physical therapist identity. Dr. Brown graduated from DeSales University with a bachelor's degree in exercise science. He received his DPT from Dominican College, and he's published research involving improving shoulder range of motion and injury prevention in collegiate baseball players, and is also a board-certified orthopedic physical therapist. He's also a certified Mulligan practitioner and trained in Red Court. Dr. Brown has a strong background in manual physical therapy and is currently working towards his fellowship in manual therapy through the Manual Therapy Institute. So, without further ado, we'll turn it over to Dr. Brown.
All right. Thanks for everyone coming out today, especially from the inpatient side. I know a few of you, so much appreciated. So, the title here, we have movement system syndromes, or also here we refer to it as movement system impairment syndromes, because we truly look at it as a whole movement system, and you're going to see how I talk about that in a little bit. As I go through the presentation, I want you to keep the title in mind. The reason I chose this title is because oftentimes I think we're looked at for what we do. Do you do this stretching? Do you do Graston? Do you do joint mobilizations? Instead of really, at the heart of who we are, So no financial disclosure and for CME. The objective today is to look through and describe what the movement system impairment syndromes are. Look at various parts of the movement system and processes resulting in our different musculoskeletal pain syndromes. Promoting the importance of using diagnostic labels for movement dysfunctions. And then describe the importance of assessing alignment and posture, the big emphasis that we're going to put on this today. And looking at movements in painful regions, the effects of movements on, and their effects of movements on the other regions. So a full term of regional interdependence, if you want to call it. And then lastly, just to promote the importance of physical therapists as the movement specialists as we really strive forward and look for more autonomy in our practice. So I had to put this in. Most of the lecture today is based off of Shirley's work. Obviously can't see everybody on the web, but here, who's familiar with Shirley's work? Or just a little bit about. Okay. So she to me almost sits on the realm of the Maitlands, the Mackenzies. Those that she really has kind of set an awesome framework and groundwork for our profession. So she's a professor of physical therapy, cell biology, and physiology in Washington, the University of Medicine in Washington. And she actually started working with the neural population first. And she started looking at people coming off of CVAs, polio, spinal cord injuries, and started using these diagnostic systems with them, and then has progressed it over the years. She's actually received a major award. She received a bunch of awards, but the Mary McMillan Award, and this is important because this is almost one of the highest distinguished honors you can receive. And it recognizes those who have demonstrated some kind of skill in the area of administration, education, patient care, and management. So I felt just based on this lecture, to give her a slide was the least I could do. Great reference for anyone. And in my references, you'll see the links to the books, the actual names of the DOIs. You'll be able to look those up. So we look at our identity, and I put this picture up of Bruce Wayne and Batman for a reason. If you ask a number of physical therapists, PTs, colleagues, what we do, what do you think their answer would be? Think about that for a second. And I think sometimes we forget our true identity of that, at the heart of what we do is we look at that movement, and we are the specialists. In 2013, she put out a paper out of the International Journal of Orthopedic and Sport Physical Therapy about how the movement system should be the identity of our profession, and that was Vision 2020 for APTA. What's funny is we actually have not had an identity in the 96 years of the existence of the APTA, which is kind of crazy. We started off as a technical field, utilizing different modalities, and I think we have much so since evolved. In this paper she published, she looks at a lot of how we're responsible for monitoring individuals, not only at the time we're seeing them, but starting to look at them across the lifespan, and looking at movement across the lifespan, and targeting not only what we're treating for, but then looking at a preventative standpoint. So the example a lot of times that I'll use is, I give my dentist example, I'll give it to the patients, and I'll say to them, how many times a year do you go see your dentist? Hopefully most of them say 2, or at least once. But why, and I pose the question, why aren't they coming to see us at least once a year then? If they're going to see them. And I know we battle insurances, and we have that to worry about, but for the most part, a lot of us have direct access. We're able to utilize that. So why are we not saying to our patients, especially patients who we have good rapport with, and we develop good relationships with, hey, in 6 months, why don't you do me a favor, come on back, come see me, let's take a look at some things. And I actually do have a few patients that do still come back and will call up, hey, I'm here for my checkup in a way. I don't want to look at the checkup, but I think we're doing the right thing in that sense. Is we're just trying to prevent injury and help cut down on some costs. Okay. Here we look at how basically movement affects every system, and the reason I have interchanging arrows there is just because it does have a direct effect on back and forth. The only system that's missing, and I thought about this, was the GI system. And I thought about an example with I do some inpatient work, and I remember I had a patient who we got him up, got him moving. The first time we moved in a few days, sat him down into the chair, and luckily the bedside commode was right there. And we got them right back into there, and I came back to one of the therapists I work with, Marnie, and I said to her, man, I am so thankful after we got him moving that bedside commode was there. And she looks at me and she's like, that's right, mobility equals motility. And so next thing I know, I'm thankful for that. But I want to talk about a couple of foundational pieces in regards to, before we go into some example, in regards to movement impairment syndromes, and that's looking at the whole pathokinesiologic model versus the kinesiopathic model. One based on that pathology is our source of pain, and the other based on that faulty movements result in some sort of pain. So the example we're to use for the pathokinesiological model is like an example of pterygium spinatus, supraspinatus, that leads to some kind of decreased shoulder strength, stability. And then we start to develop painful movements from that. Then we lose function. Does this really address the cause then of the problem? Maybe. Was the tear traumatic? Was this something that happened from a fall, from lifting something heavy, from pushing or pulling something? And in that case, then maybe in the standpoint that if the shoulder is a solid base and has good strength and good mobility, and we're not working with poor movement, maybe it was just that traumatic. But a lot of times, that's not the case. And I think that's what we're seeing on the orthopedic side is it's the kinesiopathologic model that is the movement that's causing the problem. So put X's up, because basically they are same from the 3rd, 4th, and 5th arrow down on both. It's just what starts it. And we start to look at what is causing that problem. The example I thought of was that a patient came in to me a couple months ago with a diagnosis of some kind of supraspinatus tendinopathy. Based on the models, the tendinopathy, yes, that was the pathological problem. But then I look at the movement, I started seeing that her movement was what's causing her problem. And I started to actually look at not just manual muscle testing, not just range of motion testing, but quality of movement. How is her shoulder actually moving? So on a daily basis now, she's starting to move her shoulder insufficiently. In her case, it might have been that the shoulder blade was not rotating enough upward, which caused then some faulty mechanics at the lumbar joint. So I think that's a good case of how we can see how movement really relates to the problem versus the pathology. The reason I push so much on this movement diagnosis is because I think it helps us to be specific in what we do and not just generalize. Instead of that general diagnosis, and here are your 5 to 8 exercises for the shoulder. Instead, we take it from that whole idea of a shotgun approach and honing in on, all right, there's really 2 or 3 problems that are causing the issue here, and let's progress forward. Because we know that we can provide our patients with 5, 10 exercises from home. They're not going to do 10 exercises. It's not going to happen. They don't have the time or the patience. And then just looking at the whole idea of cause and effect. And the reason I put the whole idea with the nail in the tire was we can keep pumping air into that tire. Eventually, it's going to keep losing air, and eventually, you're going to have to, just keep putting air in until you decide to replace it. So, fix the actual driving problem. The other concept that I want to talk about is the idea of muscle stiffness. This is not just due to length changes. So looking at basically the resistance present during passive elongation of a muscle and connective tissue. So the example here I want to use is the cervical spine related to the scapula, because a few of the examples I give a little later on in the presentation are specific to the cervical spine and case related to the cervical spine. If we don't have a stable base, meaning our cervical spine, our deep neck flexor and intrinsics, and we're moving and we're having too much tension in, i.e., our scapular muscles, it's going to pull from there, and you're going to get more tension in the neck. And I think you see that a lot of our patients come with neck pain and looking at addressing the scapula versus just looking at neck. In 1997, there was a study that was published. She looked and showed when she looked at the 14 females and 15 males, trained and untrained athletes, and looked at ultrasound imaging and found that there was a direct correlation behind muscle stiffness and volume. And just looking at the stiffer that these people were, and mainly it was at our elbow flexors that they had more trouble moving. The other concept I want to talk about is the whole idea of relative flexibility versus stiffness. And then the idea of, again, the movement occurs where it can. It's going to take the path of least resistance no matter what. In the example here, we look at someone, a lot of lumbar flexion. Now, it's cartoon, but we see this, we're looking in our outpatient settings mostly at someone who comes in with back pain. You'll see this a lot. And comes in, 0 hip movement, all coming from the lumbar spine. They don't know this is a problem. Their body just starts to move as most efficiently the way it can. And this is an idea of where basically lumbar spine is more flexible than the hamstring muscles. So now you're going to give a little bit more from lumbar spine, and now you're repeatedly moving more from your lumbar spine, causing strain there. So, real life example clinically I wanted to use was the idea of a pro knee bend test, or sometimes known as Eli test, and look at what's normal and then look at what's not normal. So, professors have done this test for quad length mostly. We'll start to look at just how is that, whether it's a knee patient, hip patient, but I'll use this test a lot for my back pain patients. So, basically, perform knee flexion and see, are they getting to 90 degrees of knee flexion, base test? Are they feeling a stretch in the quad? If you turn that around and start to look now, what's happening with the lumbar spine? I think we've all had cases where we bend the knee, and next thing you know, they're saying, I feel it in my back. So what you're going to start to see is more of that increased lordosis. It might come from the pelvis. In certain cases, you might see it come from more specifically at a segment in the lumbar spine, a couple segments in the lumbar spine where you're starting to see just a little bit of more hypermobility. And that's the whole idea of now taking on the anterior aspect of the body, the anterior chain, looking at the rectus being not as stiff as the quads are. So again, just idea of where they're moving from more. The reason I chose to use this is because one, back pain is probably the most common, not second most common thing we see. And if we relate it back to function, so the average American takes about 4,000 steps a day, so 2,000 on one side. If their quads tighten, every step they take a terminal stance, they're just going to hinge from their lumbar spine, or they're going to move from their lumbar spine more so than their hip. So addressing the whole idea of flexibility in the hip, an idea how you can affect the lumbar spine. Last concept that we're going to talk about is the idea of overstretched weakness, and that basically that muscle will become weak when maintained in a different position. So a couple examples that I start to think of with this is sleeping positions for patients. So patients who are side sleepers, and they sleep, and now their shoulder blade, their scapula becomes very abducted. So their middle trap and their lower trap becomes long. And based on this concept, becomes weak. Humerus starts to push forward, so now their posterior rotator cuff becomes long, becomes weak. And now they start to move in a certain pattern, and now they're just feeding into that every time. It doesn't always have to be sleeping position. That's just the example I wanted to use. It could be really any prolonged position that we're looking at, or patients are dealing with work activities, daily activities. Two key factors to look at is increased resting muscle length upon postural alignment exam. I'm going to use the scapula as the example. And then two, weakness in the muscles evident throughout their entire range of motion. So I've had talks with a few different colleagues about this, and some of my coworkers are probably tired of hearing me talk about this, but if we take the scapula and we examine someone who comes in with neck pain, and we find that it's sitting depressed, so it's sitting lower than T2, or level like T3, call it. That's going to lengthen the upper trap. It's going to lengthen the elevator scap. And so what happens then is it starts to pull more on the cervical spine, unless you have a very strong deep intrinsics of the neck, but not many people do. Now we start to look at that in movement. So now we have them move their shoulder, they reach overhead, and you see that the acromion does not really achieve full elevation. So every time they lift overhead, that muscle staying in lengthened position, and realistically what's happening is pulling on the neck. There you go. I'm going to show a picture of an example in a second. So just looking at the movement systems in general as an approach, and it's a systematic approach looking at the entire body, evaluating, diagnosing, and then treating. A lot of times we'll use our symptom-provoking tests or movement tests that provoke symptoms or pain, and then correct that faulty movement pattern, and then see, does that get better? So we start to look here at the excuse me, cause versus the source. And then I put in even further, what's the cause of the cause? Okay, so someone comes in and says, I have shoulder pain. Well, is your shoulder pain? Maybe it's due to a weak scapula. Why is that scapula weak? What's been going on there? Is it trauma? So I look for, is it micro trauma? Is it macro trauma? Was it macro trauma from a fall? Or was it more so that just that repeated thing that they're doing throughout the day, sitting posture that they're in, the way they're reaching? So say, give the example below them with sustained postures. Someone comes into you with left-sided lateral hip pain. Examine them, we find, okay, weakness in the glute medius. But what's driving weakness in the glute medius? Is it just weak? How long has it been going on for? It's been 5 years, 10 years, and as we start to look at then the cause of the cause, looking, all right, well, what's your sitting posture? I've seen plenty of patients come in, hip pain, test them out. Yeah, their hips are weak, but there they are sitting, legs crossed, lying on the side. So when they lie on their side at night now, they just promote that whole idea of the overstretched weakness I talked about. As their hip just adducts, it internally rotates. And now that glute med is just put on constant length for 6, 8, 10 hours, depending on how long they're sleeping. Versus now correcting that, let's say cause of the cause, put a pillow between their legs. Now they're sitting in more neutral alignment, hips aren't rotated, and now your strengthening is great, but if you're not looking at the whole idea of the whole picture, that's why that patient maybe comes back to you in 2 months, 3 months, 6 months. Maybe they're just not doing exercises too, but way to look at things. Just looking at a couple bullets with the movement system and how that, we're going to look at alignment and posture. There's a big push on that, because that can tell you a lot, and you'll see it in a second, just based on the scapular example. Looking at the overall movements, not only just in different positions. So standing, supine, sideline, prone, just watching how they move. A lot of times those gravity minimized positions, because if they can't move right in the gravity minimized position, they're not going to be able to move properly in a standing position. Looking at different muscle length testing and strength testing, and then obviously a functional assessment. So with this, we oftentimes look at, I talked about the whole idea of microtraumas, so an idea of what's moving too much. And but also noticing that it may be moving too much, but what around that is moving maybe too little. And the example I want to use is, we said movement's going to occur where it's available, as I discussed a few slides ago. So the example that I chose to use is some kind of excessive movement of the cervical spine with some kind of shoulder movement. Going back to the whole idea of something moving too much, maybe C5-6 is moving too much. You see that a lot of times when patients come in, they say this, well, I've got degenerative changes at C5-6, and as you have them move, you can see why that's the case, because every time they move, that's where the movement occurs from. And maybe below it, sitting in the thoracic spine, the cervicothoracic junction area, that's what's really stiff. Just looking in general neck pain, so top 5 chronic pain condition in terms of prevalence and years to loss to disability, but yet it does receive a fraction of the research and funding in regards to low back pain. Surgery is more effective than conservative treatment in short term, but not in the long term. The strongest evidence exists for movement, exercise. Bigger evidence supporting some kind of massage, acupuncture, yoga, and some kind of spinal manipulation. And that was a study taken out of the British Journal of Sports Medicine in 2017. Okay, so the whole idea of the movement system impairment is characterized by a direction of movement that deviates from the normal kinesiologic standard and is most constantly painful. Often correction of this movement will decrease pain. The example here, we look on the left. Overall, relatively call it normal cervical rotation, pretty uniform. Versus the right now, as they rotate, they start to extend. Okay, so a lot of times patients come in, I have pain turning right. And all you have to do is just, all right, we'll keep your chin down a little, try not to extend here. And you go, I have no pain. Maybe your eval's done, maybe not. So just basically, it's very simple. Shirley's model is not, I don't think, crazy complex, but sometimes it's those little things we miss as clinicians, and we're kind of just, they're right in front of us. Common syndromes of the cervical spine we'll see is the one I just listed, which she would determine as an extension rotation problem. But there also are flexion syndromes, rotation syndromes, extension and then flexion rotation symptoms. And again, they're based on faulty movement pattern and pain. So what are some contributing factors that we'll look at least that I try to look at in the cervical spine? And that's one, scapular alignment of muscles, thoracic alignment, lumbar alignment, and extremity movement happening there. Talking about just in general of lumbar alignment, a lot of times with the neck case here, maybe someone comes in and they have pain looking up. You do nothing but correct their poor lumbar alignment, sitting alignment. Next thing you know, that because you put them in better lumbar alignment, their thoracic spine is now in that position, and they move pain-free. And then looking at scapular alignment and movement, or the lack thereof of the scapula and its effect on the cervical spine. Is it depressed? Is it downwardly rotated? And then looking at a passive shoulder girdle elevation test, which I'm going to show in a second. So normal resting alignment for the scapula should sit somewhere between T2 and T7. Roughly 3 inches medial scapular border to the spinous process of the thoracic spine. Slight internal rotation about 35 degrees. When you come around anteriorly, then you should see an angulation of the clavicle. Meaning from where it runs from the sternum out to the shoulder there, about 15 to 20 degrees. And as they move then, you should start to see that the acromion starts to reach about C6 overhead. So anything out of this would be abnormal. I did my best to draw. Luckily, my wife let me draw on her there. So looking at this first position, looking to see basically where here her superior angle sets, and I put a dot there just to kind of point it, and then basically where her inferior angles. So they're, to me, like relatively not too bad in alignment there. But she does sit a little depressed. So talking again, T2 normal. When she sits there, T3, I mean that sits lower. Whereas here, very similar. So she sits kind of on both sides, a little depressed in her shoulder blade. 2 now. Now she has more depression. I kind of had to force her into downward rotation, but you see this plank. You see the scapula downwardly rotated. Okay, that happens when now your superior angle, okay, sits out here, and your inferior angle sits a little bit closer to thoracic spine. You may see a combination. It may be depressed. It may be downwardly rotated. It may be abducted. You may have a combination of things. And I think the reason that the postural alignment is so important is because it helps us to already just start to look at, all right, well, what muscles are going to be affected by this? In the case where it's abducted, your middle trap and low trap, likely. The type switch downwardly rotated, your upper trap. So I have this debate a lot of times in the clinic. My neck patients came in, they have neck pain over their upper trap, and their scapula looks something like this. And I will refuse to stretch the upper trap. Don't do it. Just because it's already sitting wrong. I might work on it, I might loosen the muscle up, but now I need to retrain that scapula. I need to retrain that position into some kind of elevation, some kind of upward rotation, in order to decrease the strain on the cervical spine. Makes sense? The other component looking at the cervical extension rotation is the shoulder girdle elevation test. So what we'll see here is limited cervical rotation. Oftentimes do low sitting shoulder. You can see her right definitely sits lower than her left. As you come through and elevate now, you start to see normalized movement. Okay. To me, that tells me that something muscular is I don't necessarily say tight, but it's just not in a great position, and that's a lot of times where the scapula comes into play. looking at a study now and the immediate effects of passive scapular elevation on symptoms with active neck rotation in patients with neck pain. So, physical therapists looked at 46 patients with neck pain, 30 women, 16 men, average age of around 45. Symptoms were obtained in two scapular positions, patient preferred and then passively elevated. In the scapular elevation position, a significant percentage of patients reported a decrease in symptoms with neck pain, as well as improvements in rotation. So looking at the specifics of the extension rotation syndrome, typically you're going to find this in your patient who has unilateral pain. Maybe symmetrical, maybe bilateral, but typically unilateral. Pain is going to be localized to the neck. They may have clicking in the neck, typically due to some kind of underlying hypermobile cervical segment. Pain often referred to the upper trapezius or even upper extremity. And then aggravating factors, as discussed before, some kind of cervical rotation, extension in this case, and then even arm activity. Partially, classic forehead posture, increased thoracic kyphosis, some kind of faulty scapular alignment. And I discussed before, you don't necessarily have to see just one. You may see a combination of a few. And then muscular adaptations, usually lengthen and weak deep neck flexors. So, starting to look then, we will see the rotation, as in the picture I showed earlier, limited. Cervical extension will happen a lot of times with rotation, could be side bending as well. That test will improve their shoulder elevation test, will improve their range of motion and oftentimes pain. You can see some kind of compensatory cervical extension or rotation with active shoulder elevation. And then in quadruped, you'll start to see cervical extension with rock backs. What do I mean by that? So, picture on the left there, you'll see arms come up, neck, pretty good alignment. Arms go up, neck goes up. So, for someone who maybe is a janitor, does a lot of cleaning, this is their movement they're doing a lot throughout the day. They're reaching out, they're cleaning, and every time they move their arm or something, that's what happens. They're coming neck pain. You can treat their neck, you can work on the joints, you can work on the muscles, but until you clean up how they really move and what they're doing daily, you're going to have the same problem. And in quadruped assessing, looking at how they look going into rock back, which is basically shoulder flexion, and just seeing normal alignment versus some kind of extension. This can be their home exercise. They can work literally on this and just work on keeping normal alignment. Eventually, you want to, translate it to function, but it's a start. Study here just looking at basically the weakness in the neck flexor, deep neck flexors, and how that plays a role in a lot of times with our patients who have neck pain. You're going to find them people who have short and stiff posterior cervical structures, dominance in their rotators like their SCM or scalenes. Macy, I've been preaching a lot about just how the upper trap becomes and can become weak, but a lot of times you'll see that it maybe is dominating the movement too. So just kind of assessing and figuring out what's the cause there. And then weakness in the serratus anterior. So what does treatment, like does the sample treatment look like for these type of patients? And it has to start with posture. Because if we're not addressing that throughout the day, it doesn't matter what exercises they do. They can do their exercises 5 times a day, but if they're sitting there 6 to 8 hour a day postures, it's okay. Going and addressing what I talked about, the oftentimes shortened posterior cervical structures there, and using something manually, just as you start to actively cervical flex as you start to work those muscles down a little bit. And then training the deep neck flexors. You can do that supine with a lift off. You can progress them at a 45-degree angle, so challenge them a little bit more. The key is, though, making sure that you're just not deviating. You're not seeing that upper cervical extension when they do that. And a couple big ones that I like to do, and Shirley will put her book, is wall slides. One being upper trap. So this picture here, you heard me talk a little bit about the whole idea of the acromion reaching C6. So there she's good. Versus someone who maybe their shoulder sits down here. Now they're going to have a constant pull of those muscles on the neck every time they move, especially with the weak base. If their deep neck flexors aren't doing their job, it's just going to pull. And then some kind of serratus wall slide. You're starting to train that. If that maybe component you're working with the scapula, if you're noticing that maybe the scapula isn't upwardly rotating enough, starting to treat that and making sure that they're training that appropriately. All inside, anytime they're doing any kind of neck or shoulder movement, that their neck is staying in good alignment and they're not extending at all from the. Usually, you see more the base of the neck there. So I started to make this more like picture interactive versus just like study, but I thought this was a pretty good study. And looking at EMGs as far as looking at middle trap or lower trap strengthening. And this was just on 2016, so fairly relevant. And so basically 21 healthy subjects looked at surface EMG, found that the middle trap and low trap were best strengthened and best activated with this exercise. So basically, shoulder external rotation, teaching scapular retraction, and then elevation overhead, which is a common thing functionally patients do every day. And that was just coming out of the journal as far as the EMG activity in those muscles. The blue indicated highest amount of activity. And then on the side there, these are not randomized control trials, but they were just put out in the Brazilian Journal of 2019, and basically just looking at the middle trap, low trap, upper trap, and its effects, and the serratus. So not necessarily your big randomized control trial, but I think just very good educational reads for the shoulder. So in a nutshell, what are we looking at with the cervical component here? Painful and limited cervical spine extension and rotation. When you do that passive shoulder elevation test, it improves their range of motion. Oftentimes they have poor deep neck flexor endurance. Oftentimes it's associated with scapular dysfunction. So I urge everyone, if you're looking at patients, please look at the scapula. I think we do a great job looking at the thoracic spine and addressing that, but we do a poor job of looking at the scapula and how it affects it. And then often associated with some kind of postural dysfunction. So clean up the postural dysfunction, it makes even the lumbar spine, maybe the way they're sitting. Start with that and see what you get. So I want to talk about what is the offending movement, and throughout the day, their prolonged positions, so addressing that. It could be a case, this member comes in, maybe it's your student from college comes in with neck pain from looking up and down at the board. They look at the board, they look at their notes, look at the board, they look at their notes. So starting to look at that. I'm just trying to give you guys a couple examples of what I'll see commonly. Sleeping and driving are other big ones. And then the reason I put the whole picture up there was an idea of being a detective and something's not working, change. Don't just keep doing the same thing over and over. And then, moving forward, I think the whole idea of why I decided I wanted to talk about this was trying to influence our profession. And I think St. Luke's Network are doing great things. Cervical Spine program, our residency, we really are on the forefront and throughout the country with this. But I think starting to integrate in what we do and who we are with movement is important. There's a paper Shirley put out in 1988, so that was she first addressed this whole concept of looking at movement. And it's, I wouldn't say now just coming out, but I think there's more of a push on it. So it's time to move forward with that. And then, as I talked about earlier, looking at a yearly movement exam. Yes, we battle insurances, but I would say if we can have them come in, insurance allows for it, the patient allows for it, anyone, I think that's worth doing. And then making a movement diagnosis. And the whole idea of this, or what are we really trying to accomplish? And I think at the end of the day, I love my different PT modalities as much as anybody. Joint mobilization, soft tissue techniques, Graston, blood flow restriction. You have a great amount of options. But helping and looking at the addressing the problem and looking at the whole movement picture helps us to address that cause more. And lastly, with the movement, I think we do this best in the movement system. There's a lot out there now on YouTube, on Instagram, and you can pretty much go online and find, oh, I can do this for back pain, I can do this for neck pain. But I think it's the whole idea of almost protecting our profession, looking at what do we need to do moving forward in order to keep it that way. Because there isn't really anybody who knows the movement system better than us. It's us, and that's about it, in my opinion. So I put a link in for basically a table of all the, I just touched on the cervical spine, but you'll find for shoulder, elbow, wrist, neck, and so on, different movement syndromes. And earlier on, I also put the book for anyone who wants to take a look at those. And then just a quick reference table for you. You print out one is just common muscles that are short, dominant, and common muscles that are long and weak. And questions?
So I'm personally on the yearly exam, but one of the things our profession in general struggles with is communication of value. In your opinion, and anybody else feel free to chime in, what do you feel would be enough value to provide that would make it worthwhile paying for it as a patient?
I think educating the patient on, without scaring them, and saying, if you don't come to me, you're going to end up with bad knees, you're going to be pain. And so I think approaching it from a educational standpoint and positive standpoint of how letting more so knowledge base, let them know how it can happen, not saying it will. And approaching it from that standpoint and just saying to them that I think that would be a good start.
What would you do in the yearly exam?
I think we would look at movement. I personally, if they have any complaints, would want to see, like if they come to me and say, no, I just want to see how I'm moving. If they come and say, hey, my back's been bothering me, not bad enough that I think I need therapy, but it's been something I deal with on, I might target it more to the back to try and look at it as an overall. If they just said I wanted to see how I'm moving, I would probably just look at almost all functional tasks in that case. I look at squatting, bending, twisting, pushing, pulling, pressing overhead, things like that, just to see. Because I think if we look at movement closely, when you have them do those specific functional movements, you know what you're looking for, you're going to find a breakdown. You don't necessarily have to be really specific, I think, in an assessment in that case in order to find a problem. I think it'll start to jump out a little bit from you. Just like the example I gave with the cartoon character of got a bunch of just bent forward. I mean, you already know, all right, there's something probably not moving well in the hips. Is it quickly correctable? Maybe. So I think that's how I would go about that approach. Yes.
So my answer to Steve's would be the value I put to parents. We're pediatric therapists. I tell parents that we are the PCPs of movement.
Sure.
We are the PCPs of exercise. As pediatric therapists, we're the PCPs of development. So you keep coming back and seeing me every year, I'm going to get your child to be that sports player that he wants to be, or play that, carry that tuba in the band. That's what he wants to do. And then there is an annual exam on APTA's website that's out there, and there's a webinar on annual checkups for both adults and for pediatrics. So the form is already on the website, and webinar.
I think it is the struggle we face is one, does the patient have value to it? But I think we can educate them enough that we put some value to it. And then secondarily, we're facing insurances problems here. But
So on a year, so the parents, I tell them, if they say to me, how long are you going to see me? I say, you're going to see me to your child graduates from college.
sure.
If you want to. And keep coming back and seeing me. And so far, we haven't had any problems at all with insurance. If we just come back to the eval, and if we think that they need an ongoing visit, then we just get the script and continue to see them, whatever, like a tune-up or whatever.
Okay.
So it's worked very well from that perspective. So I don't think this should work the same on the adult side. I totally agree with you. It's great.
What would you charge?
I think that would be based on our network as regards to charge. I don't know if there'd be a set.
What would you
recommend
charge,
charging?
Alex? What would you charge me to take a look?
You specifically. $100. You're paying out of pocket. You're coming to see me. I think $100 is hopefully at a number that you find is not too much, but have to put value to something higher too. You just get free. How much I'd love to get free movement screens out. That's not feasible. Steve.
How long would you recommend it taking? So half an hour, 15 minutes?
No, I think, and again, so I think 15 to 20 minutes to answer your initial question would be appropriate. Now, that being said, during your movement screen, if you're finding something just isn't right, isn't that enough, that's when I think the movement screen might need to stop. Or you just do a little bit more and say, hey, listen, I really think you could benefit from therapy, and then you go down that route.
How much emphasis would you place on a home exercise program, and would you consider having a follow-up, and how many follow-ups since then?
Yeah, a huge emphasis, and I actually didn't. It's in the PowerPoint that is that everyone will have access to. I didn't include it specifically for time. I want to make sure I left time for questions. There's a study, it's a case report that Shirley did, and she saw this low back pain patient. I'll just this synopsis really quick. For it was over 3 sessions over a year. Initial session, 2 months, and then 6 months, and saw significant improvements, and literally just taught them how to move right. Both bridges clammed, literally said, here are 6 movements I didn't like, here's how you need to move right, follow with me in 2 months, you move it, and went about that way. I think going back to the home exercises, it needs to be our 2 to 3, 3 to 4. Patients don't have time, nor do we really need to give them that many? If we're dealing with multiple body parts, maybe. But I think from a standpoint of physical therapists and bringing value to it for the patient on a time basis, less is more.
So I just want to clarify. So the only way you'll get access to the PowerPoint is if you email Dr. Brown. So
Yes.
please email him
Okay.
if you want it.
Thanks, Steve. Yeah, feel free to email me. I'm happy to provide that. Check online. Good. Thanks for coming.
Thank you. Make sure you sign out. If you're online, make sure you wait for the email that I'll send out and click on the link, and it'll take you right to the My Learning page. Thank you very much.